My name is Dr. Subrato Deb. I'm a thoracic surgeon. I specialize in the treatment of thoracic cancers, such as lung cancer, esophagus cancer, and so forth. Um, I work at the Baptist MD Anderson Cancer Center. Today, I was asked to review some information on lung cancer. Um, and uh, I would encourage the audience, whoever's tuning in, to reach out to me with any questions you may have, and or any clarification I may provide. I was going to also cover a few things regarding some myths about lung cancer surgery that patients often ask me about, and I wanted to go over those things as well. So, uh, lung cancer is a very common problem in the United States, and certainly in Florida. Uh, if you look at the patients treated for lung cancer, looking at the CDC webpage, um, um, the median age is 72. So this is mostly a condition of patients as they get older. Uh, Regardless of smoking history, just the aging process can put you at a higher risk for developing malignancies, and certainly lung cancer is one of them. If you look at the American Cancer Society Florida statistics, and I was going to just show you a couple of graphs that I put together. This is and if you look at this, this is the estimated number of cases of cancer in the state of Florida. Sorry, folks. And then this is the death rate. So if you look at the estimated cases in Florida, you see breast cancer is very common. Lung cancer is the second most common. And then if you look at the graph on the right, which is the estimated deaths, you can see lung cancer is the cause of death more commonly from cancer than breast, colon, prostate put together. So it is not only a very common cancer, particularly here in Florida, but it's also the number one cancer killer in the state of Florida. And so it's very important that we identify cancer at its earliest stages, particularly lung cancer, so we can treat those patients. And the best treatment, which I'll go over in a little bit, is surgery. And here's one broken down by male and female. And rates of cancer, I'm doing this backwards. The graph is self-explanatory pretty much, but you can see in men, the graphs on the left is women, and graph on the right is men. That again, lung cancer is extremely common, and it's a very common cause of death in both men and women, despite other common cancers that we talk about, such as breast, colon, prostate. So I just wanted to define the problem, which is significant. Now, we do have a CME event next week. I would encourage you folks to, whoever's tuning in, to participate in that continuing medical education event on lung cancer screening, and as well as just some basics on lung cancer through the Baptist MD Anderson webpage. You should be able to find information regarding the CME event. But I just briefly wanted to review a few words about lung cancer screening. If you look at the lung cancer screening, that was a screening program that was highly debated and contested for years and years and years. Unlike mammography, colonoscopy, prostate-specific antigen PSA checks, rectal exams, pap smears, lung cancer screening, even though lung cancer is the number one cause of cancer death in the United States, was not mainstream until about 2011 when the NIH, the National Institutes of Health, supported a study called the NLST, the National Lung Cancer Screening Trial. And this enrolled 55,000 patients, and they basically compared screening high-risk patients that they defined in that study as patients between the ages of 55 and 74 with about a 30-year history of smoking. And they compared CAT scan to chest x-ray, and they found that patients that had annual CAT scans for 3 years compared to chest x-ray, that there was a significant reduction in the rate of death from lung cancer by performing lung cancer screening, which is just a simple low-dose CAT scan once a year among this group of patients. And so this is now a recommendation by the U.S. Public Health Service Task Force, by almost all medical societies, cancer societies, as a standard of care intervention to reduce the death rate from lung cancer. And basically, the study showed that if you could identify patients at an earlier stage of lung cancer, stage 1, that you could operate on those patients, remove the cancer, and potentially put that cancer in remission. And that was the salient finding of that study, was identifying early stage cancers that could be operated upon. Because if most cancer of the lung is identified at a later stage, when patients have symptoms such as a cough, weight loss, shortness of breath, and by the time that a patient has symptoms from the lung cancer, it's usually not operable. It's usually an advanced stage. Almost half the patients that we find with lung cancer are stage 4, which is an advanced stage, and there's really not a whole lot that can be done at that stage. The lung cancer screening trial allowed us to identify patients at an earlier stage before they progress to stage 4, and then coupled with that identification of lung cancer, the second part of that's not evident is that these patients then go to surgery where they have a good operation, and that's where the benefit is then achieved, is in surgically removing the cancer. They did not look at radiation, they did not look at chemotherapy as options to treat lung cancer. They looked at surgery as the best option, and that was what was shown to be beneficial in these patients. If there are no questions, I'm going to go through some myths about lung cancer surgery, since I'm a surgeon. So one of the questions I get asked commonly is, "Doctor, are you going to crack my chest?" I hate that term, crack my chest. That's not really how we operate. Perhaps in the 70s, 80s, and 90s, surgeons used to make larger incisions to remove small tumors. Today, I would say majority of the operations performed, certainly majority of operations that we perform here at Baptist MD Anderson, are minimally invasive, meaning we use keyhole incisions, we use a camera, a robot, less invasive, minimally invasive approaches to removing all cancers, including lung cancer. And what we found is that doing a minimally invasive removal of lung cancer, which we call a minimally invasive lobectomy, or a robotic lobectomy, or a VATS lobectomy, VATS, VATS, which stands for Video Assisted Thoracic Surgery lobectomy, significantly improves not only the patient's quality of life, but they are able to leave the hospital sooner, they have less pain, there's less complication rate, and more importantly, if the patient does need additional treatments such as chemotherapy after surgery, then they're able to do that relatively quickly. We know that the sooner, if a patient requires chemotherapy after surgery, we know that the sooner the patient starts that treatment, the better the outcome. And so with the less invasive approaches, patients are, within a few weeks, they may have some discomfort, but in most cases are ready to get back to their activities of daily living, and if they need additional treatment, most of them are able to start that treatment relatively quickly, which is very beneficial. Okay, another question is, if you open my chest, will the cancer spread? Again, that's another myth. There's no data to say that opening and looking at the cancer at the time of surgery will allow it to spread. Now, I will say that there are techniques to removing cancers. There are some principles that we follow as cancer surgeons to remove a cancer that maybe not all surgeons adhere to. Um, and there are certain techniques and ways of doing the operation so that you do not manipulate the cancer or the cancerous lobe of the lung or the cancerous tissue excessively. There may be some theoretical risk in that situation in terms of spreading or seeding the cancer. And so by doing these minimally invasive operations, we actually do very little manipulating of the tissues of concern, and I don't think that there's any risk there of spreading the cancer when we do a less invasive surgery. Another myth is I will be on oxygen after surgery. Um, Again, that all depends on the patient's physiologic status at the time of surgery. If you have good lungs and you're not a smoker, but maybe you were and you stopped smoking, those are all things that portend a really good prognosis for the patient in terms of quality of life. Very few patients really need oxygen. We do a thorough evaluation before we take a patient to surgery, looking at the physiologic parameters that are important. Cardiovascular system is is one system that we look at, and the pulmonary respiratory system is another system that we look at to make sure that the patient will tolerate the operation. In most cases, if a person has good lung function, they will not need oxygen long term. There may be a requirement just in the very early period of the perioperative period where maybe they need some oxygen. But again, that's a rarity. And again, in most cases, patients do not need oxygen. Will I be bedridden after surgery? Or the myth is that I will be bedridden after surgery. Again, that's a myth. Given the fact that we can do these operations with little tiny keyhole incisions, with less pain, less disturbance of the chest wall mechanics, you don't have a big incision, all of these other things. Most patients are up and about, usually the night of surgery. I like to see my patients walking, sitting up in a chair for having their dinner the night of surgery. And then we look at ambulation, we look at moving around, walking as just like a medication. 3 times a day, 4 times a day, we like the patients to get up and walk and move around. We know that speeds up their recovery, reduces the risk of clots in the legs or arrhythmias of the heart or other complications. And so most patients are actually very active, and then those that undergo the less invasive surgery are much more active. Let's see here. Will I have a bunch of drains coming out of my body after surgery is another common question. Generally not. We follow the evidence that's published. There's some evidence looking at the number of drains that a surgeon leaves in after following a lung removal, and looking at 2 drains, 3 drains, 1 drain. And most of the evidence, most of the data supports just 1 drain to be adequate. And so we know that the lesser number of drains that we put in, the less pain the patient has. And so in our practice, we usually just place 1 drain. Now we talked about chemotherapy after surgery a little bit. That's a question that I get asked as well very commonly, is will I need chemotherapy after surgery or additional treatments after surgery? And I would say that the answer to that question depends on the stage of lung cancer after the removal of the tumor. So we do a staging process before the operation. So you have a lung nodule identified, you get a biopsy, it comes back as lung cancer. You'll see a thoracic oncology surgeon like myself or an oncologist who will then perform a staging procedures, perform staging tests to determine what stage the patient is at, and then that determines treatment. Again, in most cases of patients that are found to have lung cancer during a screening process, screening CT, lung cancer screening program, are stage 1, early stage cancers. We usually will do a CT scan and a PET scan to determine that. And that's called the clinical stage. That's the stage before surgery. Now, at the time of the operation, we would take out the cancerous lobe of the lung or cancerous lung tissue. Sometimes we don't take the whole lobe out. We do less than a lobectomy, and there's some information on that. I could talk about that all day, but there's some information that less than a lobectomy for very small tumors may be just as good as a lobectomy. But anyway, whatever lung tissue we take out, we also take out lymph nodes that drain that lobe, that cancerous area, and there's this very rigid standards regarding what lymph nodes to take out at lung cancer surgery. And we follow those recommendations to the T. So we take out lymph nodes, and then we submit all of that tissue to the pathologist, and they will then take the following week to review that pathology and give us a final diagnosis, or a final stage, I should say, which is called the pathologic stage. So the clinical stage is the stage that is our working stage that we go to surgery with, and then the pathologic stage is the stage after surgery. And that pathologic stage may change. So a patient may be felt to have stage 1 lung cancer, but at the time of surgery, if I remove some lymph nodes that has cancer within them, then that could change the stage to a stage 2 or a stage 3. And in general, if a patient has stage 2 lung cancer after surgery, then they will be offered chemotherapy. If a patient has stage 3 lung cancer after surgery, then they will be offered chemotherapy as well as radiation therapy. And what our normal practice is that we would have the patients see both of those specialists at the time of their surgical follow-up, and then discuss or review the pathology at our multidisciplinary tumor board, which we have here at the Baptist MD Anderson Cancer Center. We meet every Tuesday and we review all of the patient's pathologies and their cases and come to a consensus, which we call a multidisciplinary decision on how to proceed next with that patient's care. And that's really the standard of care in the United States. And so we would then talk to that patient about further treatment afterwards. However, I will say that in most cases, the clinical stage and the pathologic stage really don't change. It's extremely rare where we would go to surgery assuming it's stage 1 and then come out of surgery at stage 3. Maybe it's a little more common to find some lymph nodes that might make a patient stage 2, but it's very rare to change that for that stage to migrate to stage 3. And in most cases, it's probably because the clinical staging process may have missed something that was significant. But in any of those cases, whether it's stage 1, 2, or 3, the evidence supports surgery as the best option. And in some cases with stage 3, we don't do surgery, but in most cases, if it's an incidental finding of a stage 3, data tells us that removing the lung cancer, removing the lymph nodes by an oncologic surgeon tremendously improves that patient's outcome. And so surgery is really the best option for patients with lung cancer across most stages, except for stage 4. Another question I get asked is, do I need to stop smoking before or after surgery? I already have a cancer. Again, evidence is how we practice. You know, as surgeons and as physicians, we really have to tailor our practices and the recommendations and what we do to patients based on data. We are data scientists. We have to base every decision every day on data. That's the way I look at it. It's called evidence-based practice. And so the data tells us that patients that smoke have a much higher incidence of complications after surgery. And so, again, there's clinical trials, there's institutional studies that have looked at when should a patient stop smoking to perhaps reduce their risk of complications. There was some data that if the patient stopped smoking within just a few weeks of the surgery, that perhaps they had increased complications because the airways reacted in a negative way. But that's never really panned out. We feel that 4 weeks is an ideal time to stop smoking before surgery, 4 weeks prior to surgery. But any amount of time of discontinuation prior to surgery is beneficial. But the optimal time is 4 weeks or greater. So we try to ask our patients to stop smoking. I certainly personally will not deny a person an operation because they are smoking, but I would strongly encourage that patient to try to discontinue smoking to reduce their risk of complications. We also know that, again, from the data, that patients that stop smoking have a much faster recovery of lung function after surgery. So one of the interesting things about removing a person's lung is, if you look at, sorry, I'm looking at the time. I'm just rambling on here, but I'll just keep going. Is that if you take, if you look at the patient's lung function after surgery, and if you take out, say, 20% of that patient's lung function by taking out a lobe, and then you look at their lung function numbers over the ensuing 6 months to a year, in patients that are non-smokers, that lung function will actually return to levels pretty close to what they were before the operation. It's amazing how the human body, recovers from surgery and recovers from insult. But we know that patients that continue to smoke and continue to damage their lungs, that those patients don't have such a rigorous recovery of lung function, that they continue to have a compromised state. And so, if you can stop smoking before surgery, that's great. And certainly after surgery, maintaining absence of cigarette smoke to your lungs will improve your lung function and will keep you from getting another cancer. We do see that as well in some patients that continue to smoke, is they'll get a second lung cancer or a cancer somewhere else related to smoking, cervix, bladder, head and neck, larynx, those places. Let's see here. In terms of medications after surgery, again, we focus on pain control as our through what we call a multimodal approach. So the traditional options for pain was in narcotics, and they still have a role and a place in pain control, but we attack the pain through multiple pathways, not just at the nerves where the incision is, but at the spinal cord level, at the brain, with the muscles adjacent to the incision. All of these things can have an impact on the perceived pain by the patient. And so we attack all of these pathways through different varieties of medications. So most commonly, patients will go home on what we call a multimodal regimen for pain control, which includes perhaps an opiate for pain, but an anti-inflammatory agent, something for neuropathic inflammation, probably a muscle relaxant, and sometimes even some topical medications. And we use that combination, and that's been shown in data, in evidence, in studies to reduce the requirement for narcotics and reduce the chances of addiction to narcotic pending medications. And so that's our practice here at Baptist MD Anderson, is we really focus on pain control through using a multimodal pathway. And also, at the time of the operation, a surgeon can do some things to reduce the patient's pain. That's very important. And not just using small incisions and the keel incisions as I'm talking about, but also performing nerve blocks, handling tissues without trauma, gently touching things, those kind of things can have significant impact on the patient's perceived pain afterwards. And it's very important to us because we want the patients not only to have the benefits of removing the cancer, but we want them to have a good quality of life, and we focus on patient satisfaction. We want our patients to be happy. And I think I'm getting near the end here. Don't know if anybody has any questions on anything, and I don't see a whole lot. I know it's a little bit after lunch. Everybody's a little sleepy-eyed. As I said, I could ramble on and on and on. Drives my wife crazy. Well, hopefully I've answered or addressed a lot of the questions that people may have regarding the surgical treatment of lung cancer. And I tried to cover a little bit regarding some of the myths, some of the common questions that are asked by patients. I've also covered lung cancer screening in a little bit of detail. And again, I would just remind everyone that we will be hosting a continuing medical education activity on lung cancer and lung cancer screening, where we will go over some of the screening guidelines. We'll also go over some of the newer technologies that we're using here at the Baptist MD Anderson to evaluate lung nodules that are identified during a lung cancer screening event. And then I'll go over some of the surgical data that I sort of covered today, but in a little more detail in terms of some of the ways of doing the operation. What are some of the operations that we can do for lung cancer? What are some of the outcomes, some of the controversies surrounding surgery, and so forth. As I said, I work here at Baptist MD Anderson Cancer Center. I'm a thoracic surgical oncologist. I have years of experience focusing on thoracic malignancies. In the last 30 seconds or so, I'll just kind of go over, I'm a cardiothoracic surgeon and a general surgeon. So our training involves, in my case, 6 years of general surgery. I was in the Navy, so it actually took me 8 years. And then additional 3 years of training in cardiothoracic surgery. And then once we finish our training, we either focus on adult cardiac surgery, vascular surgery, congenital heart surgery, or thoracic surgery. And I focused on thoracic surgery. So that's all I do is non-cardiac chest surgery. So lung cancers, esophagus, tumors of the chest, anything above and the diaphragm, even stomach cancers, benign conditions, as well as malignant conditions. So we specialize in infections of the chest, airway, and so forth. You can call me anytime. If you have any questions, send me an email. I'll be more than happy to address your questions and concerns anytime. Thank you again for tuning in. It was a pleasure talking with this phantom audience. Hopefully everybody learns a little something. Thank you again.